I'm pleased to introduce our next speaker, Dr. Victoria Fan, who is a research fellow at the Center for Global Development, certainly one of the very important Washington institutions involved in global health, in global development, and in policy development in global development. Dr. Fan is a graduate of Harvard University, has been involved in issues of universal health insurance as well as development. And we've asked her to speak today on a very important topic, because a resounding thing you heard in Dr. Jameson's talk was how much money this is going to cost. We've asked Dr. Fan to address the issue of where should that money be invested. Her topic is more health for the money, putting incentives to work. Dr. Fan.
Professor Coates, and I'm just truly honored to be here today to be speaking with such a distinguished panel. And I'm really delighted to be commenting on this really important report in front of you, speaking from the lens of more health for the money, putting incentives to work. Does this work? Maybe this does. Okay. No. So the report has many themes, and I think for myself, I took three key takeaways from this report. The first is that countries should invest in best buy clinical interventions, particularly for non-communicable diseases, and they should also do policy interventions, particularly tobacco tax and other sin taxes. And as Professor Jameson just mentioned, that countries should also progressively provide essential, low-cost, highly cost-effective packages for the poorest before expanding coverage. And then a third takeaway is that donors should invest more in global public goods, particularly on knowledge for research and development, policy and implementation research. And I fully agree with these key recommendations. And from my perspective, I see at least three challenges associated with these recommendations. So the first is about package and politics, you could say. So nearly all of these countries have politically designed package of benefits, clinical interventions, and policy instruments, making the realization of countries having best buy interventions quite difficult. Second is that there's weak country capacity. So many of these countries lack the capacity and knowledge to technically design and expand these benefit packages tailored to their national context. And then the third is that often the donor policies are not aligned. Donors often only weakly use cost-effectiveness criteria for their health aid to countries. They only weakly support benefit package design, and there's, in general, in my view, in our work, weak incentives for value for money. So I'm just going to briefly share two reports that we did at the Center for Global Development. The first is on more health for the money, was focused on the donor side, one very large agency called the Global Fund to fight HIV, tuberculosis, and malaria. And then the second report, published 2 years ago by Amanda Glassman, our Director of Global Health Policy, on priority setting, building institutions for smarter public spending. This is more focused on the national policies to get to better design appropriate benefit packages. So on the first report, there's been a lot of repeated sort of cliches, you could say, that in countries such as India, there are only about 40% of children who are fully immunized, and yet at the same time, public hospitals subsidize open heart surgery. And so this sort of inequitable distribution and sort of benefit package design, you could say, and low value for money often results from sort of inertial, implicit, and often ad hoc resource allocation. And what drives these sort of perverse choices? Well, a lot of competing interests. I mean, you can say that healthcare is so complicated, we've got so many diseases, so many different interventions, everyone thinks it's their own priority. And yet that's juxtaposed with the fact that we're dealing with really complex politics of pharmaceutical industry, providers, payers, and of course the patients and donors. So the question is, how can countries develop priority setting capabilities and institutions? So in this particular report, they found that there is definitely an increasing demand for priority setting abilities. So on the one hand, health spending is increasing inevitably. Countries are moving towards universal health coverage. At the same time, there are lots of new expensive technologies increasingly available. And in certain countries in Latin America, we're seeing the increasing use of legal courts to make decisions on what the benefit packages should be in order to fulfill the right to health. And sometimes this has bankrupting health consequences. And despite this increasing demand, we're also seeing a limited supply of priority setting institutions. So there are only a few agencies available to actually support this type of priority setting work. And the report found only 11 agencies in the world today. And usually these exercises are usually seen as one-off exercises. and they often don't take account of the widely varying context and national costs. And sometimes they misappropriate guidance. So for example, NICE International provides their guidance for the UK, but that advice may be misappropriated by a low and middle income country for whom that may not be appropriate. And so this capacity for priority setting is not well coordinated to tap economies of scale. So I was really quite pleased when the UK NICE International announced a new initiative, and why does that show the link? Okay, so it's the International Decision Support Initiative. It's a sustainable, adaptable international mechanism to provide policymakers with a coordinated support in priority setting as a means to universal health coverage. So with regards to these first two recommendations on the package itself and the country capacity, we've got our first report. And with regards to the second issue, the third recommendation, the third challenge regarding donor policies, we have a new report that was released last year on more health for the money on the Global Fund, as I just mentioned. So this report provides a framework for value for money which could be applied to any sort of funding agency, not just the Global Fund. So there's four parts to this framework. The first is about, before the funding starts to flow, how do we allocate the resources to maximize value for money? So what interventions do we fund? Which countries do we give the money to, for example? And which key populations do we support? And a second part of this, before the money starts to flow, how do we structure the agreements to create stronger incentives for value for money? And then once the money starts to flow, what information do we have about cost data, supply chains, and service delivery costs? And finally, how do we verify the performance of the money that we've spent? So I'm just going to give a brief background for you. For those of you who don't know what the Global Fund is, it's founded in 2002 to fight these three diseases: AIDS, tuberculosis, and malaria. It's actually got an interesting organizational structure. It's a public-private partnership. It's a Swiss foundation. You're wondering, well, why should I care about a Swiss foundation? It's one of the largest funders. It's actually the largest international funder for TB and for malaria, and the second largest international funder for AIDS after the US PEPFAR, which is sort of the US flagship program for development and for global health, and AIDS specifically. And so they've dispersed since 2003 about $21 billion, with contributions about a third from the US and a number of other bilateral governments and foundations. And since 2011, they've been undergoing a number of reforms, which is another reason why we chose to focus on this particular agency. So this may be getting too much into the weeds for those of you who actually don't care so much about the Global Fund, but in our review of the Global Fund, we found that money has not always been directed towards the most effective interventions, the most cost-effective interventions, the optimal mix of interventions, or even the key populations for which it matters. And so this is a sort of a graph from a paper that we did, looking at the budgets of the Global Fund for 5 countries. And as you can see here, we were trying to link how much money is spent on key populations. This is for HIV/AIDS spending. So you can see for India and the Philippines, where it actually probably matters the most because these AIDS epidemics are highly concentrated, we were actually unable to find out how much money is going to these key populations. And sort of similarly, on another agency, PEPFAR, there was an interesting evaluation of PEPFAR last year, and this is a quote from it. So countries want to know more than what's been planned in the country operational plans. They want to know where geographically the money is going and what services are being supported so that they can identify unmet needs. So I think this emphasizes the importance of being much more transparent in where the money is going in order to best allocate and sort of ensure that the resources among so many donors are used best. So just to summarize some of the recommendations, I didn't get into this first one, but make sure that the countries spend on a menu of effective and cost-effective interventions, identify and target these key populations, have better transparency of the expenditures, and a fourth one about optimizing investments through potentially the use of modeling. The second and fourth domains are related. It's about designing the contracts between the donor and the recipient. And we found that actually funding from the Global Fund is only weakly linked to performance, that the indicators chosen were not strong measures of performance, that performance was self-reported, not representative, often based on a convenient sample, and inaccurate. And there's also weak incentives between the grant recipient and the service provider. So this is a paper published in Lancet Global Health about their performance-based financing system. And this graph just shows you that the yellow is where the amount of money that the country should have received based on their performance rating, and the X is what they actually received. Basically, it just shows that it's difficult for countries to be able to predict how much money they'll actually get, even though they fulfill their sort of performance-based financing despite the ratings that they get, it's hard to predict how much money they'll actually get. And it's also really important to pick the right indicator. So the global funds, one of their most favorite indicators is number of bed nets distributed, which we've argued is actually not a very good indicator. And this graph just shows you that there's not very strong correlation between the bed nets distributed and the percentage of people sleeping under a bed net. You've heard stories of people trying to reach particular targets for bed nets, and they'll drive in the city or the neighborhood in the country and start throwing bed nets out the window. And so clearly that's not, it may lead to some perverse outcomes if you don't have the right indicator. So our recommendations for these two areas are: we need to directly connect a portion of the funding to performance. We need to really choose the most important indicators. They need to have much more robust methods to measure these self-reported results. And a fourth area I didn't get a chance to talk about was they need to improve the subnational performance incentives between the grant recipient and the facility level. And I think the Global Fund is really moving forward to make a lot of these changes, and I don't have time to get into those positive changes today. And the final area is about tracking costs and spending. And here I think PEPFAR has done a really fantastic job in terms of measuring costs. And this is a graph from the Global Fund's price and quality data reporting system. The Global Fund is just tremendous in making its information on the costs, the prices of its drugs purchased by countries available. And so here you can just see a huge variation. So for this particular drug, ritonavir 100 milligrams, the price per patient year in South Africa is $68. That's the minimum, and then the maximum is as high as Albania and West Bank and Gaza, over $1,000. And so the question is, what is explaining these huge variation in costs, and how can we then try to tackle those determinants to then get better value for money? So the summary recommendations for this area is that we need to have a better handle on supply chain costs. We need to have a better sense of the unit costs of service delivery. The different donors need to share this costing data with each other, and the agency needs to figure out a way to actually use this costing data in their grant cycle. So just to very briefly summarize, the priority setting report attempts to may provide one sort of way to address the challenges with package politics and weak country capacity. I'm hopeful. In a sense, you could see the priority setting report as following after the Commission on Investing report's recommendations. And with regards to donor policies, we think there's still a lot more room for value for money. So thank you very much. One last pitch. We've got a website, More Health for the Money. We've got a cartoon. I invite you all to visit. Thank you so much for this opportunity. Thanks again.